So it looks like we're excited about future trials in advanced stage, in intermediate stage, and we also hope to see some interesting data from the neoadjuvant setting in patients with potential curable disease. So now there's one thing we've not talked about, is biomarker. So what your ideas about sort of what can you foresee the future of a biomarker that would help us to select patients for efficacy or to predict outcome in those patients? Any
GPC was like, expression, like it's like any target, right? You have the source of why you find a target, then you develop a ADC, a radioligand therapy, a bispecific CAR T, and use it as a biomarker for that. That's like a lot of different diseases follow this trajectory too.
I would say a lot of work has gone into biomarkers for HCC, but we just don't have a lot to show for all of our efforts. I mean, besides ramucirumab for AFP greater than 400, there's really no standard biomarker. I think there's been a lot of work to try to understand which groups of patients respond to immunotherapy. I don't know that that's very clinically relevant because now everybody's getting immunotherapy, but also a lot of those biomarkers have really not panned out. There was this thought, maybe patients who have sort of obesity-associated, MASH-associated HCC might not benefit as much from immunotherapy. But I think that story has become more complicated and doesn't seem to be holding up as we get more clinical data. So I would say right now we really don't have any actionable biomarker, and it's unfortunate.
Yeah, I agree with that completely. I mean, was initial interest on particular genomic characteristics like Wnt-beta-catenin, also TMB and others. So I don't think those have really panned out to be something, predictive of response, and I don't think that has value per se. PD-1 expression, another. I think that probably there is something to be said for the level of immune activation, however you define that, prior to treatment, but measuring that, quantifying that, and making that move into the clinic has been challenging. Hopefully, with all of these ongoing studies, perhaps there would be some more clarity. But I echo what everyone has said. There isn't a clear clinical biomarker or tumor-based marker yet that can help us select therapies for patients. And it's based on, I think, clinical intuition and the available data.
We've had a very nice, comprehensive discussion. So now let's, if you have some advice to our colleague in the community, do you have some advice for them? So each one of you can, like efficacy, safety, management, anything.
Yeah, I think, trying to be aware of all these different options that are available for your patients, and not boxing yourself into the idea of there's a TKI and the liver function that can be used for these. We have all these different therapies available, and more patients should be able to get them. And I think community still does rely a lot on local therapies alone, and trying to move away from these and into the systemic space is very important, and medical oncologists have a role in there.
I think those are great points. Echo, there are 3 FDA-approved regimens now on the basis of an improved survival. I think patients need to be aware of all of these in a sort of a shared decision-making model, and understand, the relative, benefits of each. And I think that's really great that we have those. And the second point, I think, would be that you really work closely with medicine subspecialty to mitigate toxicities of those specific regimens.
Do you have any advice?
No, I mean, I agree with what's been said. I think if I were talking to my colleagues in community, I think I would echo one of the main points that was brought up, which is we have highly effective systemic therapy now. And, occasionally I get these patients who come to see me for a second opinion, and it's basically a hospice discussion because they've had so much local therapy that they've really lost their liver function. And we want to move away from that. I think there's been a lot of excitement about TARE, especially in the community, and I'm not saying it's not an effective therapy, but when you start to repeatedly do local regional procedures to the liver, it really does remove downstream options that patients might be eligible for.
So Mark, James, Nina, thank you for the lively discussion, and it's a lot of fun. I want to thank the audience for watching the video from GI Oncology Now.